Good morning. Thank you, George. Thank you for the kind invitation. I will quickly review the alternative vascular access of TAVR, the relationship. So we have different access for TAVR. And I will speak about this access in a chronological view. So since we began in 2007, we tried and we found alternative access to the transfemoral. This is a very nice chronogram of what happened. The first one was transfemoral Transapical, did by Alain Cribier, because it was very big introducer. So he was going the aortic valve through the left atrium and the left ventricle, but it was abandoned because it was too traumatic for the mitral valve. Then transfemoral was the first approach for both the valves that we had available at that time, the balloon expandable and the self-expandable. But we still had very large bore, up to 29 French for the balloon expandable. So for this valve was developed the Transapical approach, was a mini-surgical approach. It was very, very popular, especially in the surgical community. But for the self-expandable valve, we didn't have this kind of device, and so we switched very soon to the Transaxillary, and so became all the others. So transfemoral was the first approach and still is the most important approach. At the time, we need to use also most different suture devices. The ProStar was the most mostly used. I remember that when I did my first Edwards case with 29 French with Dr. Colombo, we used 2 ProStars for closing the artery. Actually, but now we are using ProGlide. It's much simpler, and also this is possible because the new device had a smaller sheet, a smaller introducer. We had a lot of very difficult case. In that period, we didn't know too much, and we were starting to use the CT scan, and so we had a lot of complications. For this reason, we started to think to other approach. The Transapical access was the competitor, the main competitor. We knew that was not the final one, but the period we had that one. Now the Transapical access showed to be not advantageous with respect to the surgical standard valve procedure, but now 2018, now Transapical access has been gained less popularity, so we are not going to use it as alternative. The Transaxillary access was much more interesting, and this was one of the first paper that we published with the Italian Corps of Registry, that we were showing how the subclavian, now this is misnomer because actually it's the Transaxillary access, was effective. We were using that period the proximal axillary artery with surgical exposure was very effective because even if it was not very comfortable, because we were very close to the patient, to the to the X-ray beam, and also sometimes we had some difficulty in all the settle or the cath lab, but it was very easy to use because of the short distance between the introducing the aortic valve, we were able to have very good results. Personally, I started to use some years ago the distal axillary artery, which sometimes is smaller than the proximal one, but is more comfortable for the operator. And so we have also much more introducer inside, so all the device system is much more stable. Transaxillary artery has been now everybody knows that is not inferior to the transfemoral, and when compared to the transaortic and the transapical, it seems to be much more safer. In the US, where transapical access was much more used, now we see that there is a decline in the use of transapical, but in favor of increased use of transaxillary as alternative access. The direct aortic access seemed to be an alternative to transapical because the ventricle was not touched. So with the mini thoracotomy access, it was possible to insert the introducer in the ascending aorta. And there was a lot of enthusiasm at the period, but very soon it came out that is not so, there's a lot of complication and is not very safe. Transcarotid access, this is the last alternative access, very promising. First brought in 2009 by Modine in France. The first patient population, first reports were very, very promising. And unless, even if we didn't thought, but very low incidence of complication like stroke, TIA. And also when compared to the transapical transaxillary is much better. Now, what was really impressed me was, I moved from recently in another hospital. So when I asked to my vascular surgeon, I was talking to him, was discussing a patient for transaxillary. He told me that he is more comfortable for transcarotid. So I think it's very important when we consider alternative access to respect and to discuss with the surgeon how his experience. Transcaval access is very interesting, a lot of steps to do, but I don't know if it's worth because the complication rate is very high, and I don't know if there is any reason to use a vena cava for placing a valve. So, and finally, we for sure, the transcarotid aortic valve replacement needs to be used at the transfemoral artery. And we have other access, and this algorithm proposed by Modine is very, very useful, and I agree with this. And you can see that transapical, while was the first option after transfemoral, now is the last option. But when we have a patient, we discuss how to do this patient. First, I think we need to select the optimal valve. Then select the best access for this valve, and then select the best access also taking into consideration how our surgeon, vascular surgeon, cardiac surgeon is expertise. Probably in the future, we will not need an alternative access because if the patients are younger and with a lower risk profile, usually the femoral artery and the vascular access are much more easier and less likely to have complications. So I think that it's very important when we discuss about the patient to take the patient in the middle and choose the best option for him. Thank you for the attention.